Dr. Juanito Javier.
Good morning, everybody. 1 hour session. This 1 hour session of the Association for the Study and Application of the Methods of Ilizarov, Asami, Philippines. This morning we have 4 speakers lined up. We have 4 speakers lined up for you. The first would be Dr. Cosette Atutubo, who's a former fellow of mine in Ilizarov surgery here at Philippine General Hospital, and who's now practicing here in Metro Manila, and also is a consultant at the East Avenue Medical Center. She will be talking on Wallant and its role in the application of Ilizarov fixator in the forearm for the treatment of infected non-unions. The second speaker is Dr. Shelo Balse, who's a pediatric orthopedic consultant of the Ilizarov Herbis Hospital. She will be talking on chronic and open elbow injuries during the pandemic. The third is Dr. Danny Duca, is presently the president of the Asami Philippines, Medical Center. And Jose Bilingad Hospital in Pampanga. He will be talking on delayed management for orthopedic trauma, perspectives from Ilizarov surgery. The fourth speaker will be Dr. Paulo Ramirez. He's a senior resident and he will be presenting an interesting case for us to dissect. What we're going to do for this morning will be having the first 3 speakers first, and after which we're going to open the floor for questions. Thank you. Can we have please Dr. Cosette Atutubo?
Good days. So for today's lecture, we would be discussing about Wallant and its role in the application of Ilizarov fixation in the forearm, as well as the challenges that we have encountered in the OPD with our patients during the time of the pandemic. So what is Wallant? Wallant is short for wide awake, local anesthesia, no tourniquet. This is a surgical procedure that has rapidly gained its popularity here in our country since it was introduced to the Filipino orthopedic community last year. It was started in 2005 by Dr. Lalonde, who is a Canadian plastic hand surgeon who got tired of waiting long queues in the operating room. Wallant relies on local anesthetics and hemostatic agents to provide conditions suitable for surgery without the use of sedation and without the use of a tourniquet. So in this setup, the patient is awake. Therefore, we mitigate the risks that go hand in hand with the harmful effects of a general anesthesia. We also do not use the tourniquet here, so there is less patient discomfort. The procedure allows for an ambulatory setting. So there is shorter hospital stay. There is also less stringent preoperative workup. This would in turn lessen the financial burden of the patient by lessening the hospital expenses. Initially, Wallant was meant for minor procedures of the hand, such as carpal tunnel release and trigger finger release. It has then since branched out into fracture fixation once combined with periosteal nerve block. With periosteal nerve block up until this day, the mechanism of action is still unclear because of the complexity of the autonomic and sensory nerve supply of the bones. However, one theory is most common. The nerves that accompany the nutrient artery supply polypeptides into the cellular spaces of the Haversian system. This in turn would regulate the osteoclastic and osteoblastic activity of the cells. For Wallant and periosteal nerve block to work, you have to consider these three factors. First one is pain control. You do this by application of a local anesthetic, most common of which is lidocaine. Second is hemostasis, brought about by epinephrine. And the third is anxiety control. You attain this by positioning the patient in a comfortable position and properly executing the infiltration of the anesthesia into the targeted areas. For example, gauge size matters. Gauge 25 needle is preferred at upon the administration of the initial anesthetic infiltration as opposed to a gauge 90 needle. A steady hand is also preferred when administering the anesthetic because you have to keep the needle still as possible. Lastly, the position of the injection as it reaches the skin is also a factor. A more perpendicular approach to the skin as opposed to a tangential approach would inflict lesser pain to the patient when infiltrating the anesthetic. Lastly, it is preferred that you reinsert the needles if you do need to reinsert them over the numbed areas of the body. With those principles in mind, the most common ratio of lidocaine to epinephrine is 1% lidocaine to 1:100,000 of epinephrine. However, depending on the procedure that you plan to do, the ratio of these two varies. You may also incorporate bicarbonate to the mixture so that it can diminish the acidity brought about by the lidocaine upon infiltration, therefore lessening the pain inflicted upon the patient upon the injection. If in any event that you project that your surgery might last longer than 2.5 hours, you may add bupivacaine to the mixture so that you may prolong the effect of the anesthetic agents. Despite all the possible benefits of Wallant and periosteal nerve block, there are still a good deal of contraindications. Personally, I think needle phobia is the most important part because you will not be able to proceed with your procedure if the patient is scared of needles. So you have to keep all of this contraindication in mind when you offer and when you discuss the Wallant procedure with your patients. Since 2005, several papers have been published regarding Wallant and its relation to fracture fixation of the distal radius, the clavicle, ulnar shaft. And the latest one, which was published March of this year, was about a case series of fracture fixation of the radius and the ulna under Wallant anesthesia. To share some of my cases with you that I have done under Wallant anesthesia. This is a 21-year-old female who underwent plating of the radius and the ulna. As you can see here, the patient is more than willing and happy to narrate what was going on inside of her during her surgery.
So ngayon po nagtatahinga po si Doktora, mag-alenshin din siya.
The second one is a 70-year-old female who refused to have her fracture treated with a cast. She had a lot of comorbidities, so we offered the Wallant technique to her. Here you can see that she is able to follow commands, fully awake during the surgery. The last one is an isolated radial shaft fracture. You can see that the patient is doing a peace sign at the end of the video. So all of these patients were awake during the entire time of their surgery, and they're able to follow and execute instructions given to them while undergoing the surgery. This is a case of a 23-year-old male who had peri-implant infection secondary to hardware failure. As you can see grossly, there is already hardware protrusion, and the soft tissue surrounding the hardware protrusion is already inflamed. Not in the picture, however, during the follow-up, there's also purulent discharge here. Radiographically, you can see that there is a malalignment as well as atrophic non-union at the fracture site. You can see loosening and screw pull out at the proximal portion of the distal segment of the fracture site. So what we did was initially to debris and remove the implant. Prior to the surgery, we marked the areas of the incision site as well the pin insertion site. We used 25 ml of 2% of the lidocaine combined with 25 ml plain NSS and 0.5 ml epinephrine. The patient weighed 70 kilograms, so a total of 50 ml of the solution was administered to stay within a safe range of 7 milligram lidocaine per kilogram of body weight. So we used a gauge 27 here for the subcutaneous infiltration. It was infiltrated in a proximal to distal manner. 10 ml on the planned incision sites, and then 2.5 ml on the pin insertion sites. Here, we injected the anesthetic directly into the periosteum after the subcutaneous infiltration. So this is the direction of the injection and the distribution of the anesthetic agent. After administering the periosteal nerve block, we waited for a 30-minute leeway so that the epinephrine can work its vasoconstrictive effects. It takes about 30 minutes for epinephrine to kick off its vasoconstrictive effects. And then after attaining an NPRS score of 0, we proceeded with the incision and removal of the implant. Here, we started the debridement already. The implants were removed. We performed sequestectomy. Here you can see that the patient is awake all throughout the procedure. And then we applied the Ilizarov fixator as well as the antibiotic cement. These are the x-rays immediately post-op. And here, 6 weeks later, we removed the antibiotic cement spacer and then applied iliac crest bone graft. For the harvest of the iliac crest bone graft, we used spinal anesthesia for the harvesting. And then afterwards, we applied Wallant anesthesia on the forearm for the removal of the antibiotic cement and the application of the ICBG. These are the radiographs 7 months post-op. Radiographs after the Ilizarov fixation was removed. And this is the video of the patient after the removal of the Ilizarov fixator doing minor household chores using his left upper extremity. So what were the challenges that we have encountered with our OPD patients during the past 2 years? A lot of them were lost to follow-up, and then they came back with a vengeance. A fourth of them came back with pin tract infections. And then one patient was bedridden for about a year. He personally refused to get out of the bed after the application of Ilizarov on his femur and his tibia. So after the follow-up, there was also already severe atrophy of the leg and thigh muscles. There was also knee flexion contractures for the other extremity. And we were having difficulty just making him sit on the bed on his own. Some of the patients had problems with the adjustments. For those patients who were undergoing bone segment transport and limb lengthening, with those patients, some of them stopped or they had the wrong rate and the wrong frequency of the turning for the adjustment. So when they returned, the regenerate was either in a premature consolidated state, or the quality of the regenerate was poor because they adjusted too fast. So what do we do? As much as possible after the surgery and before the discharge, we give the instructions, do a demo and return demo. Ask them if they understand and if they have further questions. For my private patients, when I send them home, I send them home with instructions with visual aids. It's easier to understand instructions with pictures as opposed to written instructions alone. I also ask them to have a notebook with them, tickler, so to speak, so that they can show me the monitoring of their turning when they follow up in the OPD. I can go back and see if they missed several days or when was the last time that they turned. For the ones that needs revisions, the ones that that prematurely stop their turnings, we sit down with the patient and discuss their possible options, one of which is amputation. So we can either revise the Ilizarov fixator, try to still save what was left of the mishap, or they can opt for the amputation. If in any event that they choose that we would still be revising, I would ask for their commitment for the turning, because one patient stopped turning just because he felt like it. So on follow-up, he decided that he would still want to proceed with the bone segment transport. So prior to rescheduling his surgery, we had to explain to him his situation, other possible options for his fixator, amputation among them, and his pledge of commitment in the event that he decided that he would want to continue with the bone segment transport. Lastly, utilize technology. Philippines has proved to be the most online people in the world. So there are several social media platforms. Filipinos are very active in social media. We can utilize that to have them follow up, befriend your patients, have a Facebook page solely for your patients' needs, so that you can add them into your friends list and then message them in your messenger for follow-up reports. In any event that they cannot follow up face to face, there is still the option of video teleconsult, video consultation. Teleconsult nga nagagawa so much more with video consultation, so that you can track them. You can have regular tracking and there's no excuse for lost to follow-up patients. For example, this is my patient from Zamboanga who had an open type 3 fracture, which eventually got infected. So he was advised for amputation by a previous orthopedic surgeon, but they refused to have it amputated. Um, After the application of Ilizarov fixator, we removed about 18 centimeter of sequestrum. And then you can see here in the picture that there is a poor soft tissue coverage. He was initially, gastric soleus flap was initially done previous to the application of the Ilizarov fixator. So there was no other option. We have to get from the opposite leg, which the patient did not want. So we had to wait for the wound, infected wound, to granulate over time, during which the patient asked to go home after a month of follow-up. So I consented under the premise that every wound dressing, they would send me a picture, AP and lateral views of the status of the wound, so I can still track and ask them to come to return to the clinic if in any event that there is a need for one. I also asked the patients to send me a video of them every 3 days, maximum every week, that they are ambulating, so that I can also guide them if there is a need for modification with the ambulation, or if there is, mabantayan lang that they are continually ambulating as per ordered. As you can see here, tumataya pa sa loto yung pasyente. For government setup, we have ORCA for PGH, set up ORCA for PGH, as well as for East Avenue, we have set up a Facebook page for their inquiries, as well as for a means wherein they can follow up online for the patients. We also get their account, ask for their accounts in the social media, so we can message them directly in any event that the number that they provided, the telephone number that they provided, are unavailable. On the right, I can see here a Zoom meeting with my Ilizarov rotators. We were discussing about the premature consolidation of the regenerate, because a patient stopped his adjustments during the pandemic. So this is a regularly occurring conference with the residents. So it is also important that you have constant communication with the residents in charge. In summary, this is a procedure that relies heavily on local anesthetic and hemostatic agents. If done right, the patient feels little to no discomfort during the administration of the anesthetic agent. This is a better alternative compared to sedation and general anesthesia, because the patient is an active participant and you can have a better assessment intraoperatively, which can help guide you with your surgery. It's convenient because it's an ambulatory setting, outpatient. The patient can come in after the procedure, go home, safer than GA, of course, with lesser hospital stay. If you prefer not to do a lot of preoperative workup, therefore you get to have less cash out for the patient. Despite all its positive attributes, it's still not for everyone. You have to keep all the contraindications in mind when discussing it with your patients. And yes, it has been a very difficult actual physical checkup with the patients. A lot of them were lost to follow up. Demo and return demo is good, but it will not suffice. So visual aids as per home instructions would help better for the patients to understand, to remember, and for the physician's side to help instruct the patients on what they are supposed to do. Uh, Keeping a track record also helps with the follow-up so that you can check if they were able to follow with the schedule or not. Lastly, in the Philippines is a the Filipino people has a very high online presence. So let us use social media platforms to our advantage and set a regularly recurring either video conference with your residents or online follow-up checkup with your patients. That's all for today. Maraming salamat.
Ilizarov limb fixation and reconstruction service did some chronic and open elbow injuries during the pandemic. Let's go to the chronic elbow dislocations first. These are dislocations that remain unreduced for more than 2 weeks post-injury. Hindrances to closed reduction are the capsular contracture, collateral ligament attenuation, fibrosis, heterotopic ossification, and triceps contracture. During the pandemic, we did 8 chronic elbow dislocations who consented to surgery. There were a few others who did not consent because of fear and would rather wait out the pandemic and live with their deformities. The patients that we did were between 15 to 45 years old, equal males and females, 5 left, 3 right. The care-seeking delay was 2 to 24 months. The causes of care-seeking delays were COVID quarantine and recovery periods, fear of getting hospital-acquired COVID, limited hospital capacities, lockdowns, missed diagnoses, and travel restrictions. And sometimes we had to go to the provinces to actually do the surgeries. This is a representative case of a 44-year-old female with a chronic elbow fracture dislocation 7 months post-injury. Her 3D CT shows more detail as to what we can expect intraoperatively. This is a different patient. Sometimes we also made 3D printed models for further visualization. However, this patient did not consent to surgery. Okay, fortunately, we have been doing chronic elbow dislocations with open reduction and application of hinged elbow fixator since 2002 with a technique described in literature by our current chairman, Dr. Javier. It consists of 2 components, the humeral and the ulnar. These will be connected later by hinges corresponding to the humeral-ulnar axis of motion. The application of the humeral hinges is the more crucial step. It is always wiser to use female hinges attached to small rods, so adjustments won't be a problem. Using male hinges means that the hinge would be flush to the 5/8 ring, such that you won't be able to do longitudinal adjustments if there is displacement of the axis during tightening of the construct. Hole modifications at the 3 and 9 o'clock positions need to be done preoperatively to the 5/8 ring so that antero-posterior adjustments of the hinges of the frame can be made to match the joint axis reference wire intraop. An ulnar-based lazy posterior incision avoiding the olecranon and centered between the palpated condyles is made. Flaps are then raised. The ulnar nerve is isolated and released to avoid injury during reduction and frame application. The distal humerus is then approached, visualized, and circumferentially released using the triceps sparing approach. Once all the fibrosis and hindrances to reduction have been removed or mobilized, reduction is done and motion is tested. The elbow axis of motion is then referenced using a wire from the middle of the trochlear axis and the middle of the capitellum. This humeral component is then applied with a joint axis reference wire in the middle of the medial and lateral hinges. The 5/8 ring is then fixed distally with a posterolateral half pin and either a wire or a posteromedial half pin proximally. This is something I find easier to do without compromising stability. Then place another posteromedial half pin to fix the proximal humeral ring. And since the ulnar nerve has been mobilized anteriorly, there is no longer any danger in placing these two posteromedial half pins. The access wire is then removed to attach the hinges connecting the ulnar component, which is then fixed with one half pin per level to the ulna. Range is tested, a JP drain is placed, and closure is done. Range is tested again post-closure. The hinges are then locked and kept in 45 degrees flexion for the first 2 days post-op. Radiographs are taken. Here we didn't really fix the malunited radial head anymore as it wasn't causing us any hindrance to reduction and motion. There was no crepitus or instability during motion. On the second post-op day, the drain is removed, hinges are released, and active to active assisted range of motions are started. This is another patient with multiple injuries. He has an ipsilateral distal radius fracture and a flexor tendon transection and fractures of both lower extremities. He is seen here doing active elbow range on post-op day 2. The frame is removed after 1 month. Patients are then asked to follow up 1 month post-removal to have their Mayo elbow performance score checked. And it's usually 95 to 100 at 2 months post-op, 1 month post-removal. So what's our collective data for chronic elbow dislocations during the pandemic? From 2020 to 2022, we did 8 patients ages 15 to 45 with equal males and females. 6 had pure dislocations, 2 had fractured dislocations. There was 1 with a preoperative median nerve palsy, which is still currently improving. The care-seeking delay was 2 to 24 months. The average pre-op flexion extension arc was 35 degrees, which improved by around 70 degrees after intraoperative reduction. The pronus supination arc also improves by 50 degrees. This improvement generally improves by 20 degrees more after frame removal. This data is skewed though by 1 patient who had poor compliance with the post-op motion protocol. We attributed this to the pin site infections and multiple concomitant injuries that she had. The average Mayo elbow performance score at 1 month post-removal is 90, which is still excellent. The technique, while it is reproducible and generally has excellent outcomes, there's still some occasional post-op complications. As mentioned earlier, we had 1 multiply injured patient who was not compliant to the post-op regimen, hence the loss of motion. This is also the patient with multiple pin site infections and a post-reduction radial nerve palsy, which is now fully recovered. Techniques on standby every time we go are B2Y triceps plasty. If there is still much tricep shortening preventing reduction after a circumferential release. We also have the hand and upper X team to do an interposition arthroplasty in case the cartilage easily peels off, but the joint shape is still workable. And of course, if the joint is not salvageable anymore, even with interposition, there's always fusion, still using the same construct. We also applied elbow fixators for fusion for infected open elbow injuries. We had 2 of these patients during the pandemic, 15 and 18-year-old males, 1 injured via gunshot and 1 injured via road traffic accident. Both of them had complex open elbow injuries with coexisting fractures of the distal humerus or the forearm. There was also infection, nerve palsies, and soft tissue coverage problems. This was the 18-year-old with a 2-week-old open infected elbow fracture dislocation from a road traffic accident. We had to deal with exposed necrotic bone, a coverage problem, and ipsilateral forearm fractures. The basic construct is more or less the same for fusion. For this, we added a transulnohumeral half pin and an intramedullary wire for the radius. We were able to visualize and release the ulnar nerve. The patient had no palsy after the surgery. The defect was covered with STSG. All hardware were removed at 3 months post-op. Okay, 6.5 months post-fusion, patient is already cleared to carry weights, but has been primed for a possible bone grafting and turtle fixation of the partial union of the ulna. This is the 15-year-old with elbow injury secondary to gunshot. There was initial difficulty in achieving union at the distal humeral shaft. The exposed necrotic olecranon was also removed. Fusion and distal humeral union was observed after 4 months, after which the fixator was removed. In summary, chronic elbow dislocations and fracture dislocations seen during the pandemic were due to care-seeking delays. Open reduction and application of hinged external fixation gives early preoperative range while ensuring stability. The technique's results remain consistent with pre-pandemic data. Negative outcomes are rare and are due to poor compliance with a post-op motion protocol. Complicated open elbow injuries with coverage problems and infection can be fused using the same components with favorable results. Thank you.
Good day, dear colleagues. Thank you very much to the POA for allowing us to share with you our experiences in managing neglected fractures during these times of the COVID-19 pandemic. Whenever we see fractures such as these, we have been trained to reduce and fix the bone with the simplest method possible at the earliest possible time. Immediate nailing as soon as feasible is the gold standard of orthopedic care in this case. During the pandemic, however, the entire country and even the entire world was subjected to quarantines and lockdowns to help prevent the spread of the virus. This led to the postponement of elective surgical procedures, leaving patients with orthopedic trauma unmanaged and neglected. When the community quarantines and lockdowns were gradually eased, we slowly began seeing these neglected cases again, with the character of the fractures drastically changed. Sometimes we wish it were as easy as just putting the bone in place and fixing it. But we should always remember that on the top of the bone are the muscles, ligaments, blood vessels, and nerves. We define a fracture as a soft tissue injury complicated by a break in the bone. Any treatment of fracture should always take into consideration the status of all these tissues. This is especially true for untreated orthopedic trauma. Consider these radiographs where we see a malunited femoral shaft with abundant callus formation. What we do not see on X-rays is the effect of this injury to the soft tissues. The muscles would be shorted and contracted, making it difficult to pull the fracture fragments back into place. On dissection of the muscles, we would appreciate a lot of fibrous tissue surrounding the fracture site. Blood vessels would also be shortened and convoluted in this fibrous mess. It would sometimes be very difficult and very bloody to lift these vessels, more so if they are in close proximity to the fracture callus. The same can also be surmised for the nerves around the fracture, making them prone to injury with acute reduction. In attempting to reduce and fix neglected fractures in the same manner as we perform these for fresh fractures, we would be acutely lengthening a limb that has been in a shortened position for a long time. Acute limb lengthening for neglected fractures can be associated with major complications, including nerves and blood vessels and disturbing bone biology, leading to delayed or malunion. We need to understand, therefore, that untreated or neglected fractures are very much different from fresh fractures. Orthopedic trauma now becomes a limb deformity. We should not simply try to break the union and straighten the deformity. Instead of rushing to apply trauma principles to these deformities, we should augment these with limb reconstruction principles. In a study by Johnson in 1994, they tried to acutely lengthen shortened extremities after a malunion or non-union. They used an AO femoral distractor to lengthen the tibia by 1.7 centimeters and the femur by 3.5 centimeters. They reported incidents of transient sensory nerve loss, fatigue fractures, and non-union with this procedure. In a related study, since there was no documented maximum amount that an extremity can be lengthened for total hip arthroplasty, Kabata and his colleagues concluded that an acute lengthening of more than 8.7% of femoral shaft length has a high risk for complications caused by acute limb lengthening. In a chapter on post-traumatic reconstruction found in this book on limb lengthening and reconstruction surgery, Tetzworth stated that while most post-traumatic femoral deformities can be corrected acutely, this can only be indicated safely if the shortening is less than 2.5 centimeters. Dror Paley in his text on principles of deformity correction would even add that correcting angular deformities lead to changes in limb length that stretch the tissues. Improperly done acute correction can lead to neurovascular compromise, joint contractures, limitation of motion, compartment syndrome and increased joint pressure, and skin necrosis from stretching of the skin. These highlight the significance of the studies done by Professor Ilizarov on the tension stress effect. While we are always amazed at radiographs showing bone being regenerated by the Ilizarov method, his studies highlighted other effects not seen on X-rays. Professor Ilizarov noted that the tension stress effect brought about by gradual bone distraction increases blood flow in the limb and creates new blood vessels in the area. We commonly hear the term distraction osteogenesis whenever we talk of bone regeneration. But probably the more correct term would be distraction histiogenesis, as bone forms not in isolation, but together with the surrounding soft tissues. The Ilizarov studies showed that all tissues that are gradually stretched showed adaptive changes in response to the distraction. Even the ultrastructure of cells are also elongated. We can therefore conclude that the methods of Ilizarov are certainly very applicable for untreated or neglected orthopedic trauma. We have come a long way from the traditional Ilizarov ring fixator, which required a steep learning curve, especially for deformity correction. We are now in the era of computerized hexapod-assisted orthopedic surgery, or chaos. For the past 8 years, we have been using the Ortho-SUV frame in our practice. Ortho-SUV was developed in St. Petersburg, Russia by Dr. Leonid Solomin and his colleagues Utekin and Velensky. The Ortho-SUV software allows us to plot the position of the deformity directly on X-rays. By inputting the length and position of the 6 struts, the software will show the position on final correction of the deformity. It would then calculate and print a schedule for adjustment of the struts, shown in this example where correction was achieved in 77 days. This is the very first case where the Ortho-SUV was applied in the Philippines for a malunited femoral shaft fracture. You can see in the sequential pictures that the shortening, malrotation, and varus were all corrected by following the adjustments shown by the software in the time frame that was predicted of 77 days. It also correlated well with these sequential radiographs. One of the more important features of the software is the identification of the structures at risk. By moving the green crosshairs to the location of the vulnerable neurovascular structure and the area of greatest lengthening, the software takes these positions into consideration when it calculates the adjustment schedule. Allow us to share with you some of the cases we encountered after the lockdowns. This is a 24-year-old truck driver who collided with a concrete barrier while driving. He was initially admitted for open reduction and internal fixation using a locked intramedullary nail, However, he requested to go home due to financial constraints, and the lockdowns happened. He was readmitted 5 months after the injury. 5 months later, the segmental fractures are malunited and shortened with a proximal fracture in a greater varus angulation. We applied the ortho-SUV to the distal fracture first and performed a corticotomy at the fracture site. We then acutely reduced this fracture following the measurements calculated by the software. We then transferred the ortho-SUV to the proximal fragment and performed a corticotomy for gradual correction. You will see that we were able to restore the alignment of the limb to a more acceptable position. Another case is the 17-year-old student who was hit by a car while walking. He was also admitted initially for open reduction and nailing, also requested to go home due to financial constraints, and was caught up with the lockdowns. He was readmitted 14 months after his injury with a fixed deformity and a leg length discrepancy of 6 centimeters. X-ray showed a shortened femur in varus with abundant callus formation. Rather than making a large exposure and trying to identify the original fracture ends, we applied the ortho-SUV frame percutaneously. We then performed a small incision for corticotomy at the site of maximum angulation. These sequential X-rays showed that the correction was achieved with regenerate forming at the corticotomy site. We were able to restore the alignment of the limb. More importantly, the patient did not report any neurovascular deficits while undergoing the correction. Another case is that of a 56-year-old laborer who fell while driving a motorcycle and underwent open reduction and internal fixation of the femoral shaft fracture last February 2020. He was lost to follow-up during the enhanced community quarantine, and during that time, he was bedbound with note of knee pain. There was gradual note of an anterior bulge forming at the knee. He consulted after 3 months when the lockdowns were eased. This was the position of the limb on consult, showing a prominent knee joint. X-rays revealed a posterior knee dislocation that was probably missed at the initial consult. We tried to imagine the position of the important structures around the knee. In acute cases of knee dislocation, we usually stabilize the joint with a hinged Ilizarov fixator to allow for knee ROMs while awaiting reconstruction of the ligaments. We attempted to do the same for this case. However, even with extensive soft tissue releases, we were unsuccessful in reducing the knee joint. Fearing damage to the popliteal vessels and peroneal nerve, we shifted the fixator to an ortho-SUV frame and gradually reduced the joint. We then shifted back to the hinge after the reduction. One final case is this 22-year-old male who was hit by a jeepney while he was walking. He had a knee injury last March 2020 and was advised ORIF, but went home due to the ECQ. He consulted us 18 months after the injury with the knee in this position. Physical examination showed the knee in recurvatum with atrophy of the thigh and leg muscles. However, there was good knee RMs, but with a stiff ankle, and more importantly, there were no neurovascular deficits. Radiographs show a posteriorly dislocated knee joint with a malunited medial tibial condyle. This is better appreciated with these 3D reconstructed images. Without opening the knee joint, we applied the ortho-SUV, spanning the knee. These X-rays would show the joint being gradually reduced by following the measurements from the software. Once the joint was in place, we went in and did a hemi-plateau elevation supporting the medial condyle with fibular strut grafts. These showed the fibular strut grafts in place, and we also shifted the frame to a hinge fixator to allow range of motion once the grafts incorporated. These pictures show that we were able to restore the length and axis of the left lower extremity. And follow-up x-rays show the reduction is maintained and the fibular grafts incorporating well. The patient is able to fully weight bear without pain and has started range of motion exercises of the knee. Last year, we published our initial experience in limb deformity correction using the Ortho SUV frame. Our series showed that all planned corrections were achieved with minimal complications. Thus, we concluded that the Ortho SUV was effective for deformity correction. In summary, neglected fractures are no longer simple fractures. The bone as well as the soft tissues are contracted and have undergone changes in position and structure. Therefore, we are no longer dealing with a simple orthopedic trauma situation, but a limb deformity. Aside from the principles used in managing orthopedic trauma, limb reconstruction principles, especially of gradual deformity correction, should be thought of. Gradual correction following the methods of Ilizarov have been shown to be effective in managing deformities due to neglected orthopedic trauma. This is especially applicable for limb shortening of more than 2.5 centimeters combined with angular and rotational deformities. The use of computerized hexapod-assisted orthopedic surgery is effective in correcting limb deformities. It is nice to end this lecture with chaos. While we still live in uncomfortable and chaotic times, let us always remember that in the middle of the chaos, there is a method to the madness. On behalf of the Association for the Study and Application of the Methods of Ilizarov in the Philippines, maraming salamat po.
Very much, Dan. We can field just a couple of questions because of the time constraint. Are there any questions from the audience? No comments from our speakers? Okay. Thank you very much, Cosette, for that wonderful lecture on Wallen. I think it's going to be very useful for situations like the pandemic and even for mass disaster situations wherein anesthesia would be very difficult to get by. Okay. And Sheila, thank you very much also. That's a good lecture on our study on the chronic elbow dislocations. I think we can continue that and we can find more applications for our hinge Ilizarov fixator. And Danny, thank you very much for that wonderful lecture. I like your slide on orthopedic trauma becoming limb deformity and trauma principles becoming limb reconstruction principles for this delayed fractures management. Okay. Thank you very much. We can now proceed to the one interesting case. We could have the video by Dr. Ramirez, from JR.
Good day, doctors. I am Paulo Ramirez, senior resident in the Department of Orthopedics of Jose R. Reyes Memorial Medical Center. Today, I will be presenting a case of a leg injury whose management was severely delayed by the COVID-19 pandemic. This is DR, a 60-year-old male, consulted in our institutions for a right leg deformity. 6 months prior to consult, the patient was driving his motorcycle when he collided with another vehicle, causing him to sustain injuries to his right leg with noted bleeding. He could not ascertain whether he had an open fracture or not. He was admitted into our to a nearby hospital where he was given antibiotics and was advised to consult an orthopedic specialist. However, this was timed to Delta surge COVID in our country, leading to lockdowns and enhanced community quarantine. Thus, he was unable to seek orthopedic consult and decided to stay at home. After 5.5 months when the lockdowns were gradually eased to alert level 1, he sought consult at our institution initially via teleconsult, where he was advised to proceed with face-to-face consult. We saw the patient at our OPD 6 months after his accident. He was wheelchair-borne without any pain on his injured leg. Grossly, the right leg was noted to be in varus and in recurvatum. There were no open wounds. Pulses were full and equal with no sensory nor motor deficits. There was limited knee motion and a leg length discrepancy of 10 centimeters. The patient did not note any motion at the fracture sites when tried to move the extremity. Radiographs of the leg and knee showed a comminuted segmental fracture of the tibia displaced in varus and short position, with the middle segment displaced superiorly and posteriorly relative to the tibial plateau. The fibula also had a segmental fracture, with the proximal tibiofibular joint displaced superiorly. We did not note any callus formation around the fracture sites. We measured the anatomic axis of the tibia and found 14 degrees of varus and 9.4 degrees of procurvatum deformities. These are the salient points of this case for the consideration of our panel.
Any questions from our audience? Clarification regarding the case? Cello, you have one question? Reaction? What would you do?
Okay. Hindi ko masyado makita, sir, because the video was too small. But since this is a segmental TF fracture and walang infection, did I get it right? There's no infection. It's an atrophic non-union on both segments. Pati sa fibula, walang union. Okay. So hindi na kailangan ng fibulectomy. Since it's segmental and there's a lot of problems, I would probably do an acute correction of the proximal and then place do a gradual of the distal, because there would be more problems in opening up the distal. It would cause more non-union and a lot more soft tissue stripping. I would probably get away with doing an open reduction acutely on the proximal than on the distal. So if I were to prioritize what I would do, acute over gradual with, I would do an acute over the proximal, do bone grafting, and then just do a gradual sa distal, and probably do bone grafting as necessary.
Thanks, Cello. There's a question from Dr. Danny Caro. Maybe it can be related to this particular case. Can a 3D printing technique be used for this particular case? Danny, Dr. Dunca, do you have a...
Yes, sir.
Can 3D printing?
Yes, sir. Since it's a multi-directional multiplanar deformity, it would be better to do templating, 3D-wise. 3D templating would be better, especially for first-time surgeons. We are currently in the process of making, patient-specialized 3D models. Pero we're still, the study is still being done. And yeah, we'll keep you updated with regards to these things. We're also making soft tissues along with that, not just the bones. And since it's patient specific, we'll be doing it with appropriate imaging, CT or MRI.
Paulo, just one question. Did you rely solely on X-ray, or did you do any, let's say, CT scan for this particular case?
We relied solely on the X-rays, sir.
X-rays, and for this particular case, already sufficient. Could you
Yes, sir.
proceed now to the succeeding presentation, continuation of your presentation?
Yes. So for the plan for this patient, due to the severe displacement of the fracture fragments and chronicity of the injury, we decided to perform a combination of acute and gradual correction maneuvers to bring the limb to a more acceptable alignment that will allow weight bearing and ambulation. Our plan was to acutely reduce the proximal tibiofibular joint to reestablish the normal relationships around the knee. Since we did not note any callus formation on X-rays, we assumed there was only fibrous union of the fractures, which would be amenable to close manipulation to mobilize the fragments. We would then apply the ortho-SUV frame initially at the distal fracture site and acutely reduce the fracture. We opted for acute reduction of this site as there was no significant shortening noted here. However, for the proximal fracture, a significant shortening is noted with the middle segment displaced high up posterior to the proximal tibia. It was also very close to the common peroneal nerve, posterior tibial artery and vein. Hence, after acute correction of the distal fracture, we would then transfer the ortho-SUV to the proximal tibia for gradual correction. Here are our intro pictures. We approach the fibular head and neck laterally to isolate the common peroneal nerve and release the fibrosis around the displaced fibular head. We then inserted 2 half-threaded pins at the distal femur and 2 at the proximal fibula. These pins were attached to the half rings and threaded rods. We used this construct to bring down the fibula to its correct location beside the proximal tibia. C-arm images show the proximal fibula being distracted and reduced. We then fixed the fibula with olive wires while also retaining the half-threaded pin for added stability. The olive wires were then attached to the proximal ring parallel to the knee joint. We then proceeded to attach a ring along the middle and distal segments using half-threaded pins that were applied percutaneously. Using these rings as our levers, we mobilized the middle and distal fragments without opening the fracture sites. These are our pictures prior to the correction of the distal fragment. After attaching the ortho-SUV frame to the distal fragment, we took X-rays for inputting into the software. Screenshots from the software show position of the middle and distal segments, outlined in yellow, and the predicted position after correction, outlined in red. This slide compares the position of the middle and distal segments before and after the acute correction, showing both fragments in a more acceptable alignment. The middle and distal rings were then locked in place with threaded rods. The ortho-SUV struts were then transferred to the proximal segment for gradual correction of the fracture. Screenshots from the software show position of the proximal and middle segments, outlined in yellow, and the predicted position after correction, outlined in red, which will be achieved in 90 days. These are the gross pictures of the leg on wound inspection. The patient was discharged with instructions for adjusting the struts during the Christmas break. The patient was again lost to follow-up due to the Omicron surge. Subsequent follow-ups were irregular owing to the shifting alert levels during this time. Thus, we were also unable to closely monitor the accuracy of adjustment of the ortho-SUV. Although in these X-rays, you can note that the middle segment was gradually mobilized to its proper length. Three months after the procedure, we noted the distal fragment to have reached its desired length, although it was displaced laterally. Since the compliance to the turning of the struts was an issue, we then decided to perform an acute correction at this time, using the final measurement of the struts as predicted by the software. We also opened the docking site to remove any intervening fibrosis and inserted cancellous bone grafts from the iliac crest. These X-rays show the final position of the tibia after docking. Comparing pre and post gross pictures, we were able to restore the alignment of the leg and lengthen it to less than 1 cm of the normal. Comparing pre and post-op AP radiographs, the tibia and fibula are in a more acceptable position, although we still have 5-degree valgus of the ankle, which we accepted already. Comparing pre and post-op lateral radiographs, the tibia and fibula are in a more acceptable position, the center of the knee aligned with the center of the ankle. Presently, we are 6 months post-application of the ortho-SUV frame and 3 months post-docking procedure. The patient is bearing weight as tolerated, although he still needs crutches for balance. There is no note of any neurovascular deficits. We are awaiting full consolidation of the fracture prior to removal of the ribs. From the Department of Orthopedics of Jose R. Reyes Memorial Medical Center, thank you.
Interesting, very interesting case. I just have a question. During the reduction of the distal fracture, did you apply bone graft to that area?
None po, sir. We did not apply bone graft. We did it close.
Again, sorry, you did not.
Sorry, sir. No, none, sir. No bone graft applied.
Yes, united already.
Yes, sir.
Yeah, I was just worried because most of the time that's the fracture site that goes to non-union because of the polarity of the tibia in that case. Any questions from the audience? Cosette, any comments?
Sure, I would just want to ask for the status of the peroneal nerve, because you indicated that you applied distractor fibula, correct?
Yes, ma'am.
They made a release. They released the peroneal nerve before they start putting down the very important thing to remember. Yes, because of the very long amount of destruction that's going to be done. Danny, any word? Any comment?
No, sir, that was our case.
Anything that, particularly that should be stressed for this particular case so that we all can learn?
I think the most important part was the shortening and the position of the middle segment in relation to the tibial plateau. If you noticed, it was way posterior and
Yes.
close to the peroneal vessels and the nerve. So in contrast to what Shelo said earlier, that she'll probably do an acute correction of the proximal, we chose to do it gradually because we were scared of stretching the neurovascular structure.
Sir, just to clarify, I wouldn't do an acute correction. I would do an osteotomy over the area, chop off the proximal overlap, and then acutely correct it, and then do the rest of the correction distally over the distal segment.
Okay.
Yun yung ibig ko sabihin pala. Sorry.
Thank you. Thank
I
you.
would chop off the overlap.
So for Shelo, I think you would accept the deformity, straighten it in a shortened position, right?
And then lengthen.
Yeah, and I guess that's where the message.
It lengthens through the distal, sir.
Yeah, I think that's where the
Okay.
message is in. No, it's no longer acute trauma, so there are many options for gradual correction.
That's right. I agree. Totally agree with you, Danny. And the hexapods, the computer-assisted devices that we have, particularly the ortho SUV, or if you're used to the Taylor spatial frame, it comes very handy in this very difficult situation wherein you really have to major correction of the deformity, length, and translation, which is very difficult to do by open means because of also the soft tissues surrounding it that are all short. And you don't want to get more white hair like me. Okay, and no hair like Danny. With that, we'd like to thank all our speakers, Dr. Cosette, Shelo Balse, Dr. Shelo Balse, Danny Dunca, and of of course, our senior resident from JR, Paulo Ramirez. And with that, I would like to close this session of the Association for the Study and Application of the Methods of the Ilizarov Philippines. Thank you very much. And good day to everybody.
Thank you to the speakers of